Hi guys, Zahir again. So general surgery and placement on general surgery, what can you expect to see? What skills can you expect to learn, acquire, learn, and so on and so forth? How best to prepare yourself. So here goes. General surgery refers to the viscera, the gut, predominantly GI. So anything GI is all general surgery. So what can you expect to see here? We're looking at your conditions, whether it's acute presentations or there are chronic presentations with some level of elective surgery. So we're looking at your conditions such as appendicitis, cholecystitis, acute pancreatitis. We're looking at small bowel obstruction. We're looking at volvulus. We're looking at a whole spectrum of hernias. These are, generally speaking, your acute setting. Colitis is another one. In the elective surgery, you might see elective hernia repair, for example. You might see hemicolectomy, sigmoid colectomy, these kind of things as per the elective, which are not immediate. Stomas, you'll see lots of stomas as well. So there'll be closure of stomas on some occasions as well in theatre. So going to theatre, while we're on that note, you can go in and you can learn how to scrub up, for example, and that again is a skill that's required. You can actually see the actual surgery, and if the surgeon is able to, and they're supervising a registrar, generally what you'll find is that they will talk you through the actual process, what it is that they're going through, what structures, anatomical structures they are passing through, what they're cutting, and so on and so forth. So that's an absolutely fantastic skill, an opportunity to actually appreciate the anatomy in real without cadavers. So that's in theatre, opportunity to actually see live surgery, have it spoken through, so actually a personal guide through the structures, the anatomy, and appreciating it in real life as opposed to a textbook. And also opportunity here to scrub. There is also opportunity here when you're in the anaesthetist room to learn about anaesthesia. If again the anaesthetist, consult anaesthetist will allow you, then there's opportunity to actually cannulate, and there is also opportunity potentially, be it in the anaesthetist room or otherwise in the theatre itself, to catheterize every patient who goes through surgery for in general surgery, so for the bowel or otherwise, must be catheterized. So there's opportunity to actually catheterize. Okay, move back a little bit back to general surgery. So there are generally a number of teams in most settings. At the Royal Bolton, you've got 5 teams, colorectal 1, colorectal 2, breast, urology, and one more, I can't remember, but 5 teams. So the teams have a good number of F1s and F2s, so a good number of junior doctors. Now the junior doctors are actually sick and tired of doing all the bloods and cannulations, and so if you go out there, go to the junior doctor's office and introduce yourself and say, hello, this is me, I'm a physician associate or whatever, and I want to an opportunity to learn or to do the bloods and the cannulations, they'll be all the more pleased to hear that. It will take a load of work off their back. Now, if you're unsure how to do it, you can always ask them to just show you once or twice, and then after that you can continue to have a go at your own leisure. Patients generally, again, will be very receptive of this kind of thing. So when you feel confident that you can do it yourself, again, ask them to watch you, and then obviously that'll build your confidence. So plenty of opportunity to get your venipuncture under your belt and your cannulation under belt. Remember, patients in general surgery, particularly if they're acute, when they're unwell, patients are they undergo anorexia, so they're not eating. And when they're not eating, and then the other thing is they're generally dehydrated. Both of these conditions mean that the veins will not be as dilated. So as you might find in general practice, because the patient is unwell. So here what you need to consider is, if you find that the veins are not in the best of dilated state, then just ask them, as long as there are no restrictions, be mindful, make sure there are no restrictions, make sure that the patient is not on a fluid restriction, make sure the patient is not nil by mouth for whatever reason, be it awaiting surgery or whatever. If there are no such restrictions, then ask them to have a drink of water or the next hour or so, a couple of glasses, and go back in half an hour, and hopefully the blood vessels will be in a better state and easier to venipuncture. So that's your 2 skills there, and there's a couple of tips there. Those of them that can eat, and again there are no restrictions, having a meal, so you've got some carbs in you, that again enables the blood vessels to dilate somewhat also. Okay, in a Royal Bolton, F3, so the wards you'll be on are generally E3, E4, F3 and F4. F3 is your admissions ward. Okay, so if you want to learn your case history taking and clerking patients in, then F3 is the place to go. Here, generally what will happen is patients will have had their bloods, they'll have had an examination, they'll have had a case history, and they probably will get cannulated. So that's, of the 4 wards, probably the best ward to learn to do bloods and cannulate. The bloods you'll find once you've done your ward rounds, so ward rounds generally start at 8 o'clock in the morning. When you're doing your ward rounds, the junior doctors will have a list of patients who require repeat bloods or whatever else. You can do that there. So you can actually say to them, do you mind if I go around and do the bloods on these patients that were requested? And that will be done. Now, some of those patients will be haven't had their bloods, and that will be by the phlebs. So if you beat the phlebs, great. Make sure you take it off on the system and mark it so that they don't go back and take them again. Other patients sometimes will say, actually, I've had my bloods already taken. So there's that for you there. How best to prepare, what else can you expect rather? So we've spoken about bloods, we've spoken about cannulation. In the bloods, what can you usually measure? What we're measuring? We're measuring LFTs, we're measuring U's and E's. Okay, we're measuring CRP for infection, and we are measuring usually full blood count. So your full blood count is on a small pink syringe or red syringe. The LFTs, U's and E's, and CRP is on the brown syringes. All your patients, virtually all your patients in general surgery, so these wards, are on enoxaparin, which is an anticoagulant. Why? Because every patient, as per the trust, every patient undergoes a VTE examination, a venous thromboembolic event assessment, and the risk of. So virtually all patients on these wards are on 40 milligrams enoxaparin subcutaneous injections. So therefore, when we do bloods, we also usually measure their INR, and therefore you need a green syringe. Now remember, when you're taking blood in a green syringe, it must be full. Okay, you have to fill that one. The others within reason. So that's the enoxaparin. Okay. The other thing that virtually all your patients on these wards are on, the other medication, is tazocin. So tazocin is a broad spectrum antibiotic, and it counteracts your gram-negative and your gram-positive bacteria. The idea being, while they're in hospital, we can fight off an infection and prevent rather than cure. So it's more a prophylaxis than anything else, as is the enoxaparin. Okay. Other skills that you'll get under your belt while you're on these wards is blood cultures. So seize an opportunity to do blood cultures. Rare occurrences are your NG tubes and your catheterization, and that's why I suggested, if you've got an opportunity in theatre to catheterize, take it. The reason being, when you're on the wards, your F1s and F2s are well accustomed to bloods and cannulation. They've got that skill under their belt, so that's why they're happy for you to do it. But the NG tube and the catheterization, they also need to have their competencies ticked. So in essence, you're in competition with them. Now, there are lots of them as well, like I said. So therefore, you've got a fair bit of competition. So see the opportunity when you can, if you can do it there. NG tube, again, it's a rare occurrence. So if you do get an opportunity, seize it. When you're on the ward rounds, you'll hear which patients need these. So that's why ward rounds are super important, and it's super important to actually engage and listen to what's going on and which you. So have a list, ask the juniors to give you a list of the ward round that you're going to do, and make your own notes on it and listen in. Oh, blood's here, so make your note on it. This patient needs NG tube, make a note. This patient needs catheterizing, make a note. So what you then do is, once the ward round is done with, you go back to that ward and you speak to the staff nurse and you say, okay, that patient needed NG tube. When are you going to do it? Because the nurses usually do it. And if the junior is too busy to go back to it, then it's a wasted opportunity for anybody. So it's a good opportunity here and a good idea to make sure you touch base with the staff nurses on these wards, and that will also help you quite a bit. So that's your opportunities on that plus NG tube catheterization. We've already spoken about theatre scrubs. Bandaging, you can actually learn how to bandage patients, again with the nurses rather than the F1s, F2s. If there are patients who have got a scar that needs rebandaging, dressings, all that kind of thing, basic stuff, but again, get it there. And to tick off your competency to do subcutaneous injections, that's your enoxaparin. The guys who do the anticoagulant injections usually go around about 4 to 5 o'clock in the afternoon. So between 4 and 5 in the afternoon is when they go around giving their daily dose of enoxaparin. So you might want to hang about for that time, and again, speak to the staff nurses, just give them a heads up. Look, I'm looking to do them, and looking to do a few of these, if you will. So what time might be best for me to come around? And generally it's between 4 and 5 in the afternoon, and you can have that competency ticked. There's the occasional chance to do ECGs on these wards, and I mean it is an occasional chance because it's not very much done. If that is the case, again, seize the opportunity, but you will get much more of an opportunity to do ECGs in general medicine rather than general surgery, so don't worry too much at all about that. I hope that was helpful. Preparation. What I was going to suggest, preparation-wise, how best to prepare for this placement. Conditions, yeah, of course, just know your conditions, know the most common condition that I mentioned earlier. No one be able to recognize those symptoms, etc. And then aside from that, know your tumour markers. So know your CEA for colorectal cancer, because you will see that. Know your CA199 for your pancreas. Know your CA125 for the ovaries, because the close vicinity of the pelvic cavity. Know that, and also recognise that CTs are very commonly done here, ultrasounds are relatively commonly done here, and these are kind of the treatment of choice. Gastrographing is a solution, an oral solution that's often prescribed to patients here also. Why? So gastrographing acts as a laxative, but also what it does, more importantly, it's a bit of a dye, and what they do is they then do x-rays on consumption or on administration of gastrographing. So that's another medication, as it were, to be mindful of, that will be prescribed here on the wards. Know the conditions, know the anatomy of the biliary tree, okay? That is super important. If you're lost in that, cholecystitis, cholelithiasis, cholangitis, all of this, you will see all the gallbladder stuff. So make sure you remember what the biliary tree is, what the obstructions are, and so on and so forth, post-hepatic, pre-hepatic, around the liver, where the stones get stuck, CBD, so the colon bile duct, etc. So know all of that. Biliary tree, know the anatomy of the intestines, the small intestine, large intestine, particularly. Know where the sigmoid is, know where the rectum is, and so anatomy generally of the GI is absolutely imperative. The tumour markers are imperative, and just the general the signs, symptoms, pathognomonic features of the more common condition that I mentioned earlier. I hope that was helpful. Good luck with your placements, and yeah, I'm sure you'll learn more. And feel free to share what you've learned. Thank you very much.